Okay, so I'll be speaking on something new that I have done, not even new, 2 years back I started it. Fibrin glue to close retinal breaks in complex retinal detachments where silicone oil has been left for tamponade. So I have used only the Baxter glue. Now, glue-assisted retinopexy for simple rhegmatogenous detachments has been described previously, including by Dr. Mudit Tyagi, but that was done to obviate or reduce the need for tamponade. It has not been reported for complex retinal detachments where silicone oil is also left in situ. So about 2 years back, we had a patient with combined fractional retinal rhegmatogenous detachment secondary to PDR. The surgery was not successful because there was an open break with some membranes superior to macula. So this time we went in second time there was oil in the eye. We did additional membrane peeling and then used fibrin glue for the open break. And to our surprise really, there was a rapid retinal reattachment with minimal post-operative positioning required. And this was the 8 months follow-up of the same patient. Vision has improved, retina is attached, pressure was normal, there was no inflammation, the oil had not emulsified earlier than expected, and the glue was not seen at all. So encouraged by this, we have used it subsequently for other PDR cases where there is bleeding during the membrane peeling and the blood cannot be dislodged from the retina. The retinal breaks cannot be lasered because of this blood, but we know where the breaks are. So after attempting laser and drying the surface during fluid air exchange, subsequently the two components of the glue are instilled over the retinal breaks, the two retinal breaks. The surface has to be dry, and you can see the glue post-operatively in the first week, but it's not seen by the third week, and the retina is nicely attached with no complications. So again, a PDR detachment, two retinal breaks with some bleeding. The two components of the glue are instilled sequentially over each break. Wherever laser is not adequately possible, where it is possible, there is no use. This is another case where the break is very close to the foveal center. So after fluid air exchange, here we injected the less viscous component first. So there is a large pool created, and then we injected the more viscous. This was an error. You can see that the glue is plugging the hole, and it's not even seen by the 6th postoperative day, but the retina is attached. So then we extended the indication to other retinal detachments such as macular hole RD in high myopia, where ILM peeling is not possible or it's a failed macular hole RD like this patient. So we used it to close the macular hole at the end of fluid air exchange with very good attachment. This was otherwise a failed RD. Similarly, a young boy with a very old retinal detachment, but the macular hole was the only break. So here again, after fluid air exchange, the hole was plugged by the fibrin glue, and the glue is already not seen by the 10th postoperative day, but it is plugging the hole is closed, retina is attached. This is another patient where the retinal detachment settled, but the macular hole did not close. However, this is still success because retinal detachment is a more serious condition than macular hole. So the things we learned along the way is that the two components should be drawn separately in two different 2 ml syringes, not 1 ml syringes because those are longer, so more difficult to maneuver. And inject the more viscous sealer protein first, which is the blue top. So you can remember it as blue first because the less viscous fibrin spills and causes a large collection. So use this first, the more viscous first and then the second one, so that it clots immediately on contact and there is a smaller coagulum. Check for needle tip blockage immediately before we enter through the sclerotomy because blockage is very common with this glue, and attempts to overcome the block close to the retinal surface causes the liquid to eject with very high force, which can enlarge the retinal break and also cause excess collection. And avoid excess injection. This is the most common problem actually because just 1 or 2 drops of each component is enough. However, this is very difficult because this is transparent, and even after the two components come in contact, the glue remains transparent for some time. So the surgeon is not clearly visualizing the injected amount. So there is a tendency to over-inject, which has problems. Now, when it is injected at the macular hole or near the macular hole, there needs to be caution, because we captured one patient where you can see the glue gone subretinally from the hole near the macula, and then within few days you can see an atrophic track there. So if this happens in the perifoveal area, you would have a visual deterioration. So it should not be avoided for the routine closure of macular holes. Now also, if you inject excessive amount in a peripheral break, it can collect like a large lump under the retina and cause the break to remain open, which is counterproductive, as we happened in this patient. Subretinal glue and the break was open. So we had to reoperate, do some membrane peeling, and then reattached the retina. So in conclusion, fibrin glue can be a useful adjunct in the management of complex retinal detachments when laser for retinal breaks is not possible due to bleed, edema, or proximity of break to macular center. Glue is not seen as early as 1 to 4 weeks after surgery. No adverse effect with silicone oil in situ, no inflammation, IOP rise, or oil emulsification in the 20 months follow-up. There is a rapid retinal reattachment, and very importantly, the patient does not need post-operative prone positioning, because the break is already closed with the glue and is not dependent on the oil tamponade or the gas tamponade to keep the face down. Avoid routine use for macular holes, as it can cause retinal atrophy in some cases when it migrates subretinally through the break. And avoid excess injection, as it can keep the break open even in peripheral breaks. Thank you.